Thrilled and honored to have him here. Erik, I'll turn it over to you.
Thank you so much for that glowing introduction, Teresa. I'm just going to share my screen quite briefly. And I would just like to start by saying, of course, Teresa, thank you so much for that introduction. And it's always a privilege to be following in your illustrious footsteps. And what an honor as well to be presenting here at this Global Dinner Series, because I think the individuals and the institutions that make up what this dinner series and the spirit of this dinner series really represent has such a rich history of supporting global health, especially global mental health, which I know can often be overlooked in the global health picture. And so my name is Erik Simmons, as Teresa just mentioned, and without further ado, I'd like to get into my presentation tonight, Reimagining Global Mental Health, the Power of Psychology, Prevention, and Partnerships. Okay, let's see here. Okay. And just to do a little agenda and objective setting, listen, I know we're really getting towards the end of the year. I know that there's quite a diversity of expertise and experience sitting in the audience right now. We have people coming from academia, we have practitioners, we have individuals who might represent a hybrid model of kind of scientists and community workers, and everywhere in between. So I'm really hopeful that tonight we can focus on some material that's relevant for everyone and interesting and intriguing for everyone. And to do so, we'll focus first on some case examples of pathways to resilient communities and mental health improvements and family flourishing in vulnerable populations in Asia and Africa. We'll then transition to what I see as the kind of main course here, which is implementations. And I'll talk about some of the failures in Indonesia and successes that we're seeing in Rwanda, and then some closing points. And I'm hoping that we can all walk away with something that's relevant to our practice, or at bare minimum, a little bit of entertainment value or something to ponder as we move towards the end of the year and we enter 2022, which is, lining up to be a very another excitement-filled year whatsoever. And I'm hoping that my perspective as kind of a unique global mental health researcher also provides the foundation to get a new or novel perspective for the individuals here tonight. And I'd like to start by turning the reflection back over to you all. A little bit of introspection here. And I'd like all of us to just take a moment and imagine the first time you did something for your own mental health. And we're not going to take too long here because I have quite a bit of slides I'd like to get through, and I'd like to also open it up for questions. But in taking that moment, I really love that exercise because there is such an eclectic variety of experiences that people have that they can represent on and reflect in any given conversation, in any given circle, even when you could imagine that many of the experiences would be homogenous. Some of them are positive, some of them are negative. And what I want to highlight in there, and I think what sets the foundation or the stepping stones for us to understand, is an empathetic approach that not everyone's experience with mental health is the same, especially on a global stage. And I think some seminal findings that came out in a special issue of The Lancet about 15 years ago is that over 200 million children under 5 years are not fulfilling their developmental potential. And that number has recently been updated to estimate about 249 million children of low to middle income countries are at risk for poor development, especially in sub-Saharan Africa. Asia is represented there as well, and some strata of South America. And what I'd like to highlight here is that is just a lot of squandered potential. That's a lot of unnecessary suffering, and that's a lot of trajectories for overall life well-being that I think is unfulfilled across the lifespan, and that's really sad. And I think all of these things are amplified by the COVID health crises. And I couldn't make this stuff up, but last week the Surgeon General came out with I thought was a very, very appropriate and timely report. And it's a 53-page report on intensified mental health crises in the United States of America right now. And we see some alarming findings in this. We found that ER visits for suicide attempts rose 51% for adolescent girls. Anxiety and depression symptoms have doubled during the pandemic. And this echoes a similar report that was recently released by American Academy of Pediatrics. And I couldn't represent or sound the alarm loudly enough for how shocking and horrifying this is. When I first read this, I thought immediately, move over Stephen King. Reality is the scariest thing that we're currently encountering. So you can leave the rest to fairy tales. I think that leads us to a transition of thinking, well, things are looking bad. And I think intergenerationally, we're going to be seeing a lot of dilemmas that arise over the coming years and decades that are going to unfold here. So what can we do? And I think a lot of the solutions lie in evidence-based practices. And we're looking at some of these effects that might be exacerbated on a global stage. Evidence-based practices become increasingly important. So I'm going to talk through two examples from Indonesia and Rwanda on how evidence-based practices can be used on a global stage to help us further progress positive mental health solutions and trajectories. And I'm going to try my best here to not only represent the successes, but also the failures, because I think that's where most of the important lessons do lie. And I start with capturing coral reefs and related ecosystem services, an ecosystem of expertise. Now, you could stop me right here and say, hey, I did not sign up tonight to hear about an environmental project. And I would be inclined to agree with you. I think that's completely accurate. But I do like talking about this project because it is my inaugural experience on the global stage. And it really is a project about not only the ecosystems, marine and terrestrial, but also the human systems that interact with these ecosystems. So this is a massive World Bank Global Environment Facility endeavor that brought together expertise from different sectors and different disciplines, academics, government officials alike, all around the globe, to figure out how we could support the human systems that are most reliant on ecosystems and ecosystem services, and then, of course, the marine and terrestrial ecosystems themselves and their resources. And it brought together individuals from backgrounds from business to engineering, and in my particular role, the human element, and that is behavior change, where I was charged with designing, developing, and co-implementing a program that was called My Future, My Oceans. And it comes with a very simple value proposition. We all want the best for our families and our villages, whatever our villages may look like. And the keys to success for a better future rely on a lot of the psychosocial components, elements, and skills that underpin how we interact with the world and the people around us, right? These are very, very simple principles, simple life skills, simple psychological capabilities, but they're hard to develop and focus on and implement in our day-to-day. Doing your best, building positive relationships, solving problems, and so on. And this was really a revelatory experience for me. And I think there are a lot of merits to this program, primarily and namely that it was based on a widely successful parenting program known as Triple P, which is Positive Parenting Program, started at the University of Queensland and has had a lot of global dissemination and success. It was locally facilitated and community-based in our participatory approach. I think the way we leveraged and empowered social identities, social norms, and social structures within our networks and the individuals we were working with in our local communities was one of the key advantages and benefits of the program. And then just the way we focused on a lot of the constructs that surround our overall well-being and mental health, things such as psychological capital, hope, optimism, resilience, and efficacy, parenting skills, because we know that this was intergenerational and it was a lifelong endeavor, so whole households would be affected, techniques from cognitive behavioral therapy, and then building and empowering psychological and social capabilities. And I'm not going to go into the details of what this means, what the results were, because as mentioned, this is not an environmental talk. I don't want to focus on that. But I think there are some higher order or more global things that I learned from this and that have allowed me to transition to future roles. Firstly, that family units are an incredible conduit for change. Change is a family affair. Secondly, that change takes a village. It's very hard to accomplish as an individual or not being supported by a system. And change is about building capacity across the lifespan. Now, I finished this program feeling unfulfilled, feeling a little unsustained. Like there was a bit of a void left with me, and there's two reasons for that. Firstly, I felt we did a great job of focusing on the parental generation, but not so much the children. And we didn't capture the outcomes for children that would lend me the knowledge and courage to say that those effects are going to be rolling over to future generations. And secondly, I was baffled, absolutely shocked that millions of dollars were pumped into the overall project enterprise across the many different tools that were developed from the World Bank. And that the second the project terminated in terms of the date that it ended, all operations ceased. All of the efforts kind of evaporated. It was this as if Thanos had snapped his fingers, or, you dropped a sugar cube into a glass of water. I was absolutely shocked that everything had just seemed to stop functioning, which brought me to think, why might that happen? Or why might we be seeing evidence-based programs or promising fledgling evidence-based programs that aren't taking the next steps? Which brings me to the research program on children and diversity, where I currently sit, where we focus on contributing to risk, resilience, and factors contributing to risk and resilience in children and families. And the one thing I really like about RPCA is that there is a focus on capacities and capabilities, not just deficits. I think a lot of the time when we're talking about models of global mental health, we're talking about disorders. We're talking about over a clinical or critical threshold. And that's dangerous because it leaves out a lot of the distribution. It leaves out a focus on empowerment, prevention, and positive psychological change for the rest of individuals who exist on the planet who aren't currently experiencing a disorder. It's not to say that shouldn't be a focus. It just can't be our only focus. And secondly, that they focus on implementation. And that is, how do you actually get high quality of effective programs to be supported by policies and implemented well into vulnerable communities around the world, especially in low to middle income countries? And RPCA builds on a rich history of ECD interventions. So once again, also focusing on the children element as well as the parents and parenting programs. And we have about a richness of a couple decades here from the preschool project that have now been following cohorts for generations, up into and through adulthood. And what we see is these first 36 months of life are crucial. They set the building blocks for growth and lifespan trajectory in a positive manner. And through the various projects that are represented here on the screen, and we don't need to go through all of them, what we need to identify is that by using play-based home visiting programs and various ECD interventions, we can see educational attainments, employment outcomes, increases in language, socio-emotional skills, regulation, relationships across the lifespan, and even mitigating some of the effects of poverty. Which brings me to Sugira Muryango. It's the second program and case study I'm going to talk about today, which translates into English as Strong Families and Thriving Children in Rwanda. And once again, keeping into account, I've just come from a program. I'm a little dissuaded, disinterested in the whole process. Well, what's the point if we can't really see these things sustained across time? But I first like to give some features and elements of the program and some of the results before we talk about some of the better things that I see in this program that were failing or lacking as deficits in my previous program. And I'm going to talk today about a cluster randomized design trial that took place a couple years ago. And I'd like to mention that we currently have a broader trial taking place right now. We're still waiting on the results for that. I'll be excited to come back in a few months and talk about that one. But for the time being, we'll talk about this clusterized randomized design and all of its graces and results. And I'd like to introduce you to our sample. Once again, I don't need us to get bogged down by the details here. But what I would like to highlight is the vast degree of adversity that our sample is facing. These are incredibly vulnerable populations. There's a lot of compound adversity in Rwanda that I'll talk about in a second. But for this particular slide, I'd like us to focus on the bottom line for the caregivers. About 22.8% of them don't know how much schooling they've had or have had no school. And a vast majority beyond that, 47.5%, are under 6 years of schooling. And when we look at the children, we see similar disparities and deficiencies and gaps when it comes to growth and what's known as stunting. For those unfamiliar with the term or the concept, that's anything that's seeking to inhibit or provide any obstacles for the cognitive, physical, or socio-emotional growth trajectories of what's expected of a child. So we see that there is a lot of stunting happening in the sample as well, which is not great as we're talking about trajectories across the lifespan and seeing positive global mental health gains. We don't want to start on a basis of stunting. So for our caregiver mental health, another thing that was a little bit concerning for us as we began is that we're seeing 45% of our sample is screening positive for at least some mental health symptom, right? Once again, facing incredible adversity, not diversity, incredible adversity. And I think that contributes to this problem here, as well as 19% experiencing some form of PTSD symptoms. See a prevalence of daily hardships that I think are, things that come synonymous with a lot of poverty around the world. But we're seeing things such as daily hardships of not having a job, not having enough money, experiencing a lot of death, injury, being assaulted. And we see that a vast majority of our sample, once again, has experienced at least one, if not many more, of these hardships. And that also speaks to the trauma, I think, that we see in our prevalence of trauma. The checklist we use, we see that a lot of the individuals in the samples we were working with have also experienced trauma. Things such as house destroyed, having to flee somewhere, a lack of security. When we think about our hierarchy of needs, it's a really difficult proposition for you to present to me, hey, you should be focusing on anything, stability of your mental health, your health aside, when you're experiencing such discombobulating effects of things such as having your house destroyed or not feeling secure in where you are. And so that, that aside, I think Rwanda presents a lot of interesting things, right? Because within our target beneficiaries, they're experiencing some of the remnant or resonant effects of the genocide that took place 30 years ago. There's also an HIV and AIDS epidemic. There is poverty that's currently being experienced there as well. So I think there's a lot of what we might call compound adversity taking place, but there are a lot of benefits. And Rwanda is a beautiful country. And the one thing I've realized from working there so far is that they're incredibly industrious, incredibly productive, incredibly keen and eager to use best practices to make sure that everyone in their communities and population is supported. And so what we can do is we can work within those systems and we can say, hey, listen, there's a lot of vulnerable families that are called Ubudehe ones as a classification system in Rwanda. And we can look at the risk factors as I briefly articulated there. And then we can devise and derive from those active ingredients and components, behavioral change systems here that can be implemented as complex interventions that lead to longitudinal effects that we can track across times for both children and caregivers. And, listen, at the end of the day, all this aside, I get really excited about this stuff because I'm just a fan of the science. And I really do appreciate all the care that went into the design and the architecture engineering this. And I think what we see in these modules, as I might have mentioned, this is a house visiting program. So they're trained interventionists who go every week to deliver these 12 modules. And I'll talk a little bit about the workforce in the later half of the presentation. But in this, every week you receive a home visit, you get active coaching on the various modules you see in front of you here. And this covers such a panacea of things that are crucial for family bonding, early stimulation and development, as well as parenting capabilities. And I'll talk about a couple of elements of this program that really excite me and I find to be really intriguing that I think set Sugira and Muryango apart from the rest of the pack. One of which being a 15-minute play session that takes place where there's active coaching involved and there's locally sourced materials. So you don't need to order a whole bunch of stuff brought in, but we know that parent-child interactions and play are crucial for not only development, but bonding in human species and beyond. Engaging male caregivers, flexible scheduling to accommodate fathers and other male caregivers increases their rates of participation. And once again, as we know, there are many advantages to having multiple caregivers, to having fathers, grandfathers, uncles involved in the process of child rearing. And that ends up being beneficial not only for the child and their life development and their mental health, but also for the father as well. Local proverbs to communicate core messages, another thing I find to be brilliant. One thing I've always found incredibly perplexing and a little bit annoying is developing interventions in countries where they're not going to be delivered, and then taking anecdotes, cultural references, or motifs or themes that don't make any sense for the target population. So the fact that all of the core messages were adapted with the help of the target community, the end users being engaged in the process, that was very, very important to the delivery of this intervention. Reducing violence as well. So there is a reduction of violence component that I think is one of the core and most elemental. This sits at the nucleus of the efficiency and effectiveness of this program. And this is something is kind of rare to be supplemented as a part of an ECD home visiting program. But we know that violence can have such disastrous effects on everyone involved in the household, and for the value of its, the merits of its own advantages, violence is bad, and we'd like to try to reduce that as much as possible. So there is a reduction, a violence component that helps to improve mental health of not only caregivers, but of course allows for more adjusted children and for them to thrive across their lifespan. So I'm going to talk very briefly about the interventionist effects before we get to the second half here. And I know I didn't mention this on the onset, but I'm very eager to have a bit of discussion at the end. So I'd like to get through all the slides, and then I'll open it up for questions, and we'll see where the relevance and interest lies. But I'm going to give a very abbreviated effects space for this particular case, the CRT that took place a couple of years ago. And what we see in caregivers from pre to post is that they have an increase in playful activities, the dietary diversity that they're able to provide for their children and then consume themselves increases as well, increased care seeking for health-related factors, decrease in child exposure to violent discipline, reduce victimization and intimate partner violence among mothers, and decrease in mothers and fathers showing depression and anxiety symptoms. For the children, right? Because I think the children play such a crucial role in where we're going as a future of populations and societies, and being able to take the charge pioneering global mental health moving forward. So making sure they start out as well equipped as possible is important. And looking at the ages and stages questionnaire, 12 months later after the intervention was delivered, so we're looking a full year after, we see increases in gross motor skills, fine motor skills, their communication ability, the problem-solving scores, personal and social. So we're talking more emotional, regulational capabilities. And once again, represented here, decrease in exposure to violence and decrease to exposure of intimate partner violence within the household. Incredibly crucial, incredibly important. And I'd like to close here with some quotes, because I think qualitative data provides a richness and a nuance to the program it's hard to capture sometimes in just those numbers. And for you to get a really good sense of what's happening here and how these more collective, cohesive, elegant models of meshing together and stitching together a couple components can really lead to these synergistic effects of positive mental health. We see things such as, mothers and fathers being proud of their children being able to participate. They feel like it's supporting them well. And I especially find myself captivated by the quote by the father here, saying that he's able to manage stress caused by poverty a bit better. He's reducing the violence, and he's finding coping mechanisms to support himself rather than taking it out on his family. I think that's really important. And we end here with a similar theme as my last intervention, which is, my first and once again, beginning introduction to this global stage. With a united family, anything is possible. Once again, family units are incredible conduits for change. And I think through the household and through family units, we're capable of enacting and empowering incredible changes across a vast variety of different domains. In this case, it's mental health, but I also think it's the environment. And I also think it can relay itself, or the nucleus of that change process can lend itself to other processes. However, the one thing I found problematic is that when we put the onus, the impetus of change solely on the household, it's bound to fall over. And we see interventions that are short-lived in their effects, that last maybe 6 months to a year, and then people forget what was delivered. We see a focus on individual children, and not the family unit, communities, or service providers. So once again, the responsibility and the motivation sits on the shoulders of a family and a household rather than the system at large. And we see solutions that are highly brittle and dependent on stable conditions. That is, if anything is to change within the system, and we know that systems are incredibly dynamic, policies change, political will change, stakeholders change, then we see solutions kind of crumble and evaporate and erode. So what we need is dynamic developmental and ecological approaches to begin thinking through how we can implement interventions in a multi-stage, multi-level type approach that can support intervention and evidence-based practice, so we don't see that erosion and that fading of a lot of the wonderful work that's taking place and being developed. Which leads us to implementation. And I'm going to take a deep breath and give you all, once again, a couple seconds. Feel free to put your response in the chat if you feel so inclined. I'm not going to be calling on people tonight. How long you might think, or that you would estimate, it takes something that's been validated or demonstrated efficiency in research to translate itself to business as usual, service provided, or clinical practice. Give about 5 seconds. I'm not going to look at the chat, and I'm not sure what anyone had in their mind, but if you had estimated it takes an average of 17 years, you would have been exactly right. I know lots of us are familiar with this figure and this quote, but that's the honest truth. Currently, as it stands, it takes approximately 17 years for research evidence to reach clinical practice or dissemination. And I think that could even be longer when we're considering community-based practice or implementing on a global stage. And that's asinine. To me, that's ludicrous. I'm not that old. So 17 years is a long time for me. And I think that's because we were so reliant on this kind of antiquated model where we thought that research really did flow through this very linear and logical pipeline, from starting in our early fledgling stages and then slowly building up and just hitting practice to what we now know is that implementation is an absolute minefield. And if you step on any one of these mines, you're at risk of blowing up and destroying all progress you made. Things can fall off by the wayside and not be adopted by the individuals that you sought out to work with, to co-design with, and to improve the lives of. And these can look like many different things: training and hoping that things get implemented, inevitable need for adaptation that just doesn't happen, poor matches to the resources because you're not working within the systems that already exist. And as we all know, as we're seeing what I think they're calling the Great Resignation, I think it's pretty hilarious, but there's a lot of staff turnover that can result in a loss of expertise. And I really love this comment. This is an adapted quote. I'm not sure who started it, but you can have the greatest product program, drug treatment in the world, agnostic of industry. If you don't focus on how population receive your thing, it doesn't matter. And this is my great attempt at graphic design here. But, as we see, I know everyone who's had someone in their lives who's had a brilliant idea, and it might have been you even. But when it actually comes to the minutia of the details and executing that, sometimes these ideas fall by the wayside and we fail. And I like to think of metaphors and analogies here. One of my favorite is for the botanists, agriculturalists, horticulturalists out there. I can't keep anything alive to save my life, but I'm sure some of you can. And to say I could genetically engineer the best seed that's ever existed, on the face of the planet. But if I don't have the right soil for that seed to thrive, there's no point in me having the seed. It's bound to see itself on a shelf somewhere rather than flourishing in actual soil. So before we get any further in this implementation science conversation, and we round third here in discussing how implementation science might take shape in an evidence-based program globally, let's provide some definitions. Implementation science is a study of methods to promote the integration of research findings and evidence into healthcare policy and practice. Implementation research is a scientific study of the use of strategies to adopt and integrate evidence-based health interventions in a clinical and community settings in order to improve patient outcomes and benefit population health. Or as I might colloquially put it, it's the art and science of doing. It's execution. It is making things happen. I think it very much so is a creative endeavor just as much as it is a scientific one, because sometimes it does take you generating a couple of novel ideas that might be, outside of what's currently done in silos or in the university setting, and maybe even a little bit of disruption as you're generating things that might be useful for implementation. And there are a lot of core issues when it comes to implementation. And this is just a small subset. This is certainly not an exhaustive list, but just to get our minds geared toward some of the barriers and obstacles that might arise and emerge when you're thinking through implementation. Things like affordability and cost efficiency, valid screening practices for services or referrals, what actually works for local stakeholders, enabling environments, as we just kind of talked about there, partnerships and building local capacity to sustain things when projects end, and understanding drivers and barriers within a dynamic system, because as we know, priorities often change. So, I get to this crescendo here where how do we actually sustain impact and quality, which, as I mentioned with Sugira and Muryango, we're currently involved in a massive scale up and expansion of the cluster randomized control trial, which is going out to about 10,000 households. And accompanying that is a multi-level implementation strategy that's known as the Play Collaborative. And it engages local and national government and stakeholders to enhance dissemination and sustainability. And these last couple of minutes here, these last 15 minutes, I'd like us to explore some of the components, tactics, and strategies that are listed below that are really useful in getting this program to be something that will be sustained and used and hopefully generalized to the populations that need it. And implementation models can very much so be based on evidence, based on theoretical models as well. As we see here, the Play Collaborative is very reliant on the exploration, preparation, implementation, and sustainment model. I'm fond of models and I'm also not. My advisor and supervisor, Teresa, has a line that I'm going to steal here because I think it's so brilliant. Is implementation models are a lot like toothbrushes, and there are a lot of them out there and everyone has one, but you don't really want to use anyone else's and you're always a little bit reluctant to share. And I think a lot of implementation models do a good job of capturing process and capturing some of the structural and thematic components that underpin implementation. But sometimes we can get stuck in this nebulous abstraction and in this realm where we're just kind of sitting and not actually doing. So one thing that I find very, very frustrating, oftentimes when I'm sitting in presentations, is people go, hey, listen, we know that leadership is incredibly crucial to getting things done and getting things adopted. That's great. I'd love to hear what that actually looks like. So to be the person I would like to see in the world, I have compiled a whole bunch of different strategies that the Play Collaborative uses to help the implementation at scale. And the first is playing with partnerships. Play with partnerships here. I think all of the implementation work that's done, a lot of that work that's done with evidence-based practices requires a symphony and a collective of individuals who have cultural and professional value and investment in what's going on. I think without that culture, without that structure of leadership, without the ability to work with others, you're bound to see failures across your system, and you're bound to see your evidence-based program fail as you tend to scale or as you tend to hit obstacles. So I'd like to first give a nod to our many implementers, funders, and government partners who make the work possible. Speaking of systems, systems is really important to me because I think it's often overlooked. The strategy for us to reach hard to reach populations is we leverage, empower, and integrate into already existing infrastructures in Rwanda. And that is the VUP, which is Rwanda's flagship social protection program for vulnerable families. And this really is a win-win. Why? Because Sugira Muryango gets delivered to vulnerable populations that we'd like to target. And the Rwandan flagship social protection program is able to increase their capacity and capabilities, their faculties for referrals and service provisions. They're able to collect data, and they're also able to hit their KPIs, their key performance indicators, as to what they seek out to do through their mission. So really in this merger, we see a win-win scenario, and the whole is greater than the sum of its parts here. What else? Tell me a little bit about the people you might be asking. Who's actually doing this stuff on the ground? And what we see is a structure here from our national level to our village level that actually mirrors and is symmetrical to the way by which Rwanda organizes a lot of their governmental departments as well. So once again, leveraging and working within systems that already exist, so you don't have to reinvent the wheel. And within these systems, we have various different levels from institutions to individuals. We have supervisors, we have cell levels, we have villages, which are the interventionists. And we have it coordinated where they're doing a lot of discussion with each other. They're meeting quite regularly. And we find that to be incredibly important to develop what's known as a C team. And within the C team, we have individuals coming from different backgrounds, expertises, able to enhance what's known as cross-site learning, able to enhance problem-solving initiatives, and able to work together to make sure the work that's happening is going through a lot of iterative cycles of improvement. As I mentioned earlier, we rely a lot on community health workers, and this is known as task sharing or task shifting for those unfamiliar. What this technically means is that we're taking tasks that are usually delegated or relegated to highly specialized individuals, and we're then training a non-specialized workforce to be able to accomplish or engage in those tasks. And this vastly improves our ability to deliver global mental health resources because you're leveraging community health workers and non-specialists. We operate through plan, do, study, act cycles, which is kind of what it sounds like. It's not too complicated here, but it's actually a really important thing for quality improvement and getting to problem solving in real time. So you're not having to deal with issues in the back half or after you're getting effects or collecting things. You know, if a problem is sitting within your system, you don't want those inefficiencies to cause disruptions throughout the entire stages of your implementation. You want to start problem solving and troubleshooting like any good business or enterprise would do. And I have a couple examples here, and I think it's really timely, of course, with COVID, but some things that come up are things like transport, right? So members who are actually on the ground within these systems can discuss with each other and say, it's really hard for us to get around. And they can organize, come up with strategies and tactics that allow them to rectify the problem, take the problem, if it's unrectifiable, to individuals and organizations who might be able to help. So on and so forth. The same goes for attendance. You know, we're seeing, because of COVID, that space was something that just wasn't quite available for our individuals, and data is very expensive. So as we see, these are incredibly pragmatic problems that have the ability to absolutely dismantle and deconstruct an evidence-based program in its efforts to implement. So having a plan, do, study, act cycle is something that's incredibly crucial for real-time solutions to very realistic problems. And as we see, once again, COVID-19 adapted things like procured PPE, enhanced health and referral tracking, and alignment with government protocols is all made possible through our PDSA cycle. I'd like to talk briefly as well about our quality improvement through Fidelity monitoring. Fidelity monitoring is making sure that the quality and the competence of what's being delivered is as trained and as expected, as defined by our theory of change, which there's some very exciting work happening right now on validating those mechanisms that underline how we expect to see those longitudinal outcomes take shape. And this takes the form of many things, right? Weekly play collaborative discussions for planning and training, in-home observations from cell mentors, feedback delivered as you're going through the process of doing your home visits across those 12 weeks, sample videos, and feedback that's compiled from the videos to the vast cohort that's delivering. Generating a political will, absolutely crucial. There's no way you'll ever see a generation or a second generation or a legacy of a program without the support from the individuals locally and at a national level. And that's something we take very seriously in our multi-level implementation approach and multi-strategic implementations approach. And what you see represented here is some policy briefs, some partnerships with the World Bank, once again, lots of district engagements that we engage in, and then some letters of appreciation from some of the communities and villages that we work with. Going digital, another important feature, and one of my favorites, because I think especially given the COVID era, it'll be important to support mental health while also making people feel safe. So having digital and asynchronous support where people can access training videos, they can, contact their networks, they can see real-time feedback of their own practices and delivery is incredibly crucial. And I think it helps build that community and culture of delivery as well. And then our final point here is a focus on costing and analysis, because it's super important for efficiencies and the long-term sustainability that we understand how much we're being asked and how much institutions and organizations might ask to pay, especially if we're talking about government. We know those budgets have to be incredibly tight. So we're currently engaged in a costing analysis as well, cost benefit scenarios. And we have a couple interesting findings, one of which, of course, which is not going to be a surprise to most people. But as we continue to scale the program, the cost per family and cost per session improves, gets cheaper, that is, and a benefit cost ratio as well. So you're knowing for society and for the families, communities that you're targeting as beneficiaries, for every dollar invested in the program, we're seeing a return of approximately $3.8 to $5, which is incredibly powerful for political stakeholders and decision makers at the policy level. Because of course they're seeking ways to improve their country, and they need that type of information feedback to go back and make a case for what's taking place at the local level and how that might impact the economic at the national, if not global level as well. So these types of analyses are crucial for buy-in, and they're also crucial for being able to make a case for sustainment and sustainability. So I'd like to close here with a couple slides, and I'm going to be incredibly discreet and concise in these because I think it's important that we just focus on what's really important here at the higher order, or the more global level of the things we've talked about today, from the case studies to implementation and its practice. Evidence is only the first step, right? And we saw that in my failures in Indonesia, and we're seeing that in successes in Rwanda. But once again, we're at a crucial juncture here where we are seeing a expansion and rollout, but we're still not guaranteed another iteration. We're not guaranteed another cycle of provisional service or being supported. So implementation is just as important. And if you're doing anything otherwise, you're doomed for failure. Prevention requires a proactive focus on systems, and that is beyond just social systems, that's beyond the family unit systems, that's logistics, that's policy, that's economic systems. And it requires us to think about how we can use the tool of foresight, how systems might change dynamically to build more resilient solutions and more resilient systems that can map in at certain leverage points to make sure that we don't see unstable results or things start to dissipate or not be as effective when things change. And then of course, partnerships. I can't speak to this enough, but if you have a strong team who are all invested in the culture and leadership of what's going on, then you're bound to see the ability to problem solve, to work together, and a lot of cultural and leadership investment and buy-in as to what comes next. I know we have a lot of individuals from different backgrounds here, so I just like to, give a little bit of relevance to practice, because I hope there's something that everyone can walk away with that's insightful, or if nothing else, something to think about. So as researchers, how can we investigate systems more effectively? And by systems, I mean incorporating that into how we design our trials to capture a lot of the indicators that represent the social ecological spaces around the households and individuals we're targeting. Practitioners, how can we solidify more research partnerships? If you're concerned by your evidence-based program lacking or having a deficit in its evidence, then there is no better place than your local university to start figuring out how you can establish ways to further promote and enhance global mental health. And for your hybrids, how can you sit in the hybrid trial space to bridge the gap? As we're talking about implementation, we're talking about a lot of things that have to do with feasibility, acceptability, cost, leadership, all of these brilliant things, but we also don't want to lose sight of effectiveness and efficacy. So how do we sit at that nexus and make sure that everyone is playing fairly, and there's a lot of longevity around evidence-based programs, and we can reduce the time. To actually seeing evidence-based practices in action. Just a couple closing points here. The story continues. I'm not here to say I'm definitely an atypical global mental health researcher. I'm not here to say I have all the answers. So I think there are a lot of challenges that are ongoing, some of which being focused on implementation earlier. I think taking into account dynamic systems and embracing messiness and intellectual humility, because we certainly don't have all the answers. And a lot of it comes from conversations, dialogues, and drawing from local expertise, ideas that already exist out in our world today. So we don't have to, once again, go about contriving these massively complicated systems when current existing solutions are out there. So I'd like to close just as we began, all of us to take a moment and imagine the first time you did something for your own mental health. And further, I'd like us to take another moment to consider what you might be able to do for global mental health communities within your ecosystem or within your strata. And with that, I conclude, and I'm happy to take any questions or comments.
Great job, Eric. So we can turn it over to the attendees. I know we've got people from a bunch of different disciplines. Just go ahead and unmute yourself and ask your question, or put it in the chat.
Or put it in the chat. All works.
Jane, do you want to ask a question?
I do. I was just wondering if we're going to go back to seeing each other, or if we're staying on this slide. So I was kind of holding my breath.
Yeah,
for a
let's
second.
do that. I'm sorry.
Okay.
Let's go back to that. I'll stop the share. Here we are.
Oh, okay, great. Yeah. Let's see. I guess you can't see me. Do I have it turned the wrong way?
We see your table.
Oh,
There we
you
go.
are. Okay.
Hi,
Sorry.
Jane. Great to see you.
Hi, nice to meet you. I'm familiar with the lab and the amazing work, and it's very nice to be introduced to you and all that you're adding to the picture. I guess I went and I looked at your LinkedIn page and saw when you graduated from your PhD, and I was curious if the things you were pointing out towards the end that were very much systemic stances, whether in the training you just received, if that was present, because why does intervention take 17 years to see itself get to the field and implementation and in ways that it should show up? So I'm just wondering if the training process is yet not including enough of the skill set that you're talking about.
Absolutely. Excellent question. Excellent observation. I think it's very astute and I think it's very timely. I think one of the issues is that's lacking as a preliminary precursor to anyone who wants to operate on the applied stage, is learning about some of these more implementation-based principles. One thing I commonly hear, especially in my previous project, was, oh, those things will work themselves out, or, oh, it's just common sense. But then we see, a absolutely eviscerated end of a project where everyone goes in their separate directions. We see absolutely no impact on the ground or buy-in within the local communities. And I think that's because it's lacking, once again, that precursor focus. And as you mentioned, the training necessary on the front end to make sure that's coming in with a bit of foresight. So we're getting these things even close to right. I don't think we have to get it exactly right in the beginning, but if you don't have that focus from the onset, you're doomed for failure. And I think that's what we saw in our previous project.
Great. Anybody else have questions for Erik or comments just about the topic of implementation science and global mental health? One thing, Erik, oh, here's a context question from Laura. Yeah, go ahead. Do you want to read it, Laura?
Yeah, I was just thinking back to your earlier slide about COVID and wondering, when we're doing implementation science work in cross-cultural settings and COVID affects each place so differently because this affects, the way lockdowns and restrictions are placed on communities. And so how do you think that this changes the way that we think about mental health in these settings? And then when we're implementing implementation science projects, besides just listing this in the outer context of our implementation science framework, what do we need to think about as we deliver this intervention in these settings in a post-COVID context?
Thank you so much, Laura, and spectacular question. I'm so glad you mentioned the back half too. I think a lot of us might feel comfortable sometimes, I think is misguided, in simply listing that in our framework, in our outer context, and saying, yeah, but that COVID thing's happening, we know it is, here it is in our model, as opposed to seeing how that translates or converts to actual actions on the ground. In Indonesia, I was fortunate enough for that not to be a factor because the project actually ended at the very end of 2018. So we, we had a couple more months before COVID was really taking hold. But in Rwanda, I think a lot of what was mentioned in terms of the PDSA cycles, as well as a lot of the focus on the implementation as it was going on. So a lot of that real-time tracking that was taking place has allowed us to at least think about how we can convert, translate, adapt, and adopt new practices that can account for COVID being a disruptor. So one of the things I like to point to, of course, is the securing of PPE materials. That home visiting is difficult for COVID, right? Because you actually have to go to somebody's house. And if you're going to multiple people's houses, that can be a little dangerous. So PPE equipment was important, as well as a lot of the digital adaptations you see today, I think are born of or conceived from a lot of the concerns surrounding COVID.
Oops. I'm just going to ask Erik, ask you, but also Teresa, are you seeing more utilization of implementation science and research methods since, I don't know, let's say in the last 2 years, when people were sitting around their computers more and trying to think about the world and how to do things? Are you seeing an acceleration of awareness or action?
Teresa, would you like, I think it's actually an interesting exercise. Teresa, you're a bit more steeped in the field and the network. So I am happy to, give my kind of new novice take on what I see happening currently, but it'd be great to hear what you think is currently happening as someone who's been invested and so engaged for years.
Yeah, why don't you start? My Wi-Fi is cutting here
Okay.
out here and there, so I want to make sure.
Not a problem. I think an issue and a frustration for me is I see more of a focus, which I think is great, but I see a lot of that being paid in lip service rather than actual action. So I see a lot of individuals using a lot of the buzzwords and phrases of implementation science and using that to kind of say, well, yeah, we have real world implications with the work that we do, and here's our implementation science frame, without actually looking at the strategies, without actually incorporating hybrid models in their designs, without actually doing the necessary activities and steps to fully integrate implementation science tactics and methods into our approaches. So I do think the excitement is there, and I think the buzz is continuing to improve and increase, but I'm still not as satisfied as I like to be with what I actually see happening.
Yeah, I would agree with you, Eric. I think there's a lot of increasing awareness of the concept of implementation science, but then there's a lot of watering down of rigor where people say, well, I'm a scientist and I do implementation, or I'm interested in implementation, thus I'm doing implementation science, rather than realizing that there's a discipline, a journal, textbooks, models, theories. And the more we all start, building off what's already been done in health services research and applying that to global mental health and child development, it's only going to help us advance the field with more seriousness and more rigor. One last question.
I think you muted, Jane.
Yeah, one last question for you, Eric. I was wondering if you could just talk about finding the win-win with partners like the World Bank when we're thinking about things like, all right, we've got this play collaborative that's scaled to 3 districts, but you've got the government with its own interests and orientation and incentive structures, and then donors like the bank with their incentive structures and orientation and vision and mission. How does an implementation scientist come into that and really use those opportunities to, get everyone on the same page and get somewhere further?
I think that's, once again, another incredible question and topic area that's going to need a lot of progression. And I'll be the first to say, the answers kind of sit behind a veil of abstraction, and it can seem that way at a lot of times because we can point to topics and themes that we know are important, but actually, executing and implementing them can be very tricky and require a lot of, delicate strategic, methodologies. And some of it even comes down to just relationships, partnerships, and timing of things. But the one thing I would say is decoupling this notion of a zero-sum game across institutions. And I know to an extent, resources are finite. I know for governments and for organizations and beyond, resources are finite. But when we think that way, and we can get defensive and territorial about the types of resources we have, we can sometimes forget that we're all on the same team. So I think a bit of grace. I think a lot of collegiality. I think a lot of reminding ourselves and establishing at a baseline, here are our objectives. We're all trying to seek to improve the world, especially global mental health, together. I think when we start with that basis, it's a lot easier to navigate and conflict resolve across institutions and get everyone geared and oriented in the same direction, rather than saying, okay, well, we're seeing holdups on this end. There are other priorities taking shape. So I think it really does start with that value proposition. I think that's where change really happens.
Excellent. And speaking of teamwork, your amazing team member, Matthias, shared the World Bank CEF concept note and some of the publications. So if anyone's interested to learn more about the intervention, they're in the chat. And unless there's any burning questions, we can wrap up a really wonderful presentation and a rich discussion. I just want to thank Erik again for his amazing presentation and inspiration for the group, and for all of you who are joining us, even though we didn't offer you free dinner. We really appreciate you being here.
Next time.
And look forward to the chance, like Jane said, when we can all really convene again in person. And just thank you all. So wonderful.
Yes.
Job.
And I would second that, just put emphasis on it. Thank you so much. This has been an incredible experience. I wish everyone, a happy and healthy holiday season. Please do enjoy. And I look forward to future engagements with all of you and being able to work together. So thank you so much for the opportunity.
Wonderful. Thank you so much, Erik. Happy holidays, everyone. Take care.
Thank you. Bye.